Hello, it is so good to be here with you. I am getting in the nick of time to record this presentation in Endometriosis Awareness Month in 2026. Earlier this month, I presented at an event by the Limestone Coast Women's Health Collective called the Endo Convo. And there are a few of my patients who missed out on attending that. So I am jumping on to record my presentation, perhaps even with a little more detail than I was able to in my time slot that evening. Firstly, and importantly, I'd like to acknowledge the Bowendick people as the traditional custodians of the area where I live and work and where my clinic is, and respect the long and ongoing spiritual relationship of the Bowendick people with country. I'd also like to pay my respect to my teachers and mentors, past and present, and my patients who teach me every day. So here I am in front of my clinic on Elizabeth Street. I finished physiotherapy at the University of South Australia at the end of 2017. I then completed my Masters of Clinical Physiotherapy in Continence and Pelvic Health over West at Curtin University in Perth. And I am an Australian Physiotherapy Association titled Women's, Men's and Pelvic Health Physiotherapist, but my passion is working with women, and that is why my clinic was born at the start of 2024. So before we go on, I think it's important to acknowledge and establish 3 things that we know to be true. So endometriosis is a whole body neuroinflammatory condition. Endometriosis lesions are not always a direct cause of persistent pelvic pain. And multimodal physiotherapy is effective for persistent pelvic pain. And I just wanted to have a acknowledgement of the girls and women who are suffering with persistent pelvic pain, who have not yet received a diagnosis of either endometriosis or adenomyosis, and acknowledge their difficult journey. It is becoming a bit of a diagnostic odyssey for endometriosis, at least 7 years. So you will hear me talk about persistent pelvic pain more broadly because I think it's important to acknowledge that group of people without diagnosis. So as a part of this presentation, I was asked to prepare for you 5 takeaway points or 5 key points, and here they are. So the first one is persistent pelvic pain is not just about one organ. Your pelvic floor supports you and it needs support too. Surgery can be helpful, but should not be the only treatment. Persistent pain changes your nervous system, and whole person care is what helps most. So let's kick off with point number 1, which is persistent pelvic pain is not just about one organ. So let's have a look here at the pelvic floor. This is a bird's eye view looking in to the pelvic floor. So I'll just jump up. Here's a pelvis, usually on a little bit of a tilt at the front of the hips here. So we're looking down and in. And so what you can see is the deep pelvic floor muscles there. So we were like this. And if we flip like this, you can see the superficial pelvic floor muscles here. And so within the pelvis, we have our pelvic organs. I've got some little tiny ones to show you here. So we've got the bladder at the front, the bowel at the back, and then in the middle we've got the cervix, a stretchy muscular tube that we know as the vagina. Then we've got the uterus, fallopian tubes, and ovaries. And you can see these all depicted here on the screen in a side profile view. And they're supported at the bottom there by the pelvic floor muscles. Just wanted to show you this picture. This is called the homunculus. It is our brain's sensory map of itself. And what I wanted to show you here on this homunculus is that, yes, the genitals are on it, but I'm hoping what you can see is that the pelvic organs aren't actually on it. And so our brain actually has a fairly muddy map of what's going on inside our pelvis, which is why it's important to focus on more than just one organ when we're thinking about persistent pelvic pain. So let's have a look at this a little bit deeper. So thanks to the Pelvic Pain Foundation of Australia, I was able to purchase this amazing resource, which is a pad that I use in the clinic to help explain this concept to people within their own individual contexts. If we zoom into the bottom of the pad there, you can see we've got a little bit more of a detailed map. So at the top, you've got the brain, then down to the spinal cord, and you can see there's an arrow going up and into the brain and an arrow coming down along the spinal cord and out. And then what you can see is lots of black lines there. And those black lines are going to all sorts of different things. Let's have a look at what they are. So down the bottom, there's the pelvic floor muscles, which includes one of the deeper hip muscles called obturator internus. We'll talk about that in a sec. You can see the bladder and the wee pipe, which is the urethra. You can see the ovaries, the fallopian tubes, the uterus, the cervix, and the vagina. And you can see the rectum and the end of the bowel, the rectum, and the anus. And what you can also see up hovering around at the top there is endometriosis. And so because all of these tissues and organs have this black line going to it, I wanted to highlight that black line as being the nerves. And you can see that those black lines all join up and meet up at that same spinal cord level, which is that funny butterfly looking thing over there. And because all of those nerves meet up at the same level, the same nerve root, that is called convergence. So they meet up at that same level. And then the information from all of those organs travels on the same pathway to the brain. And then the brain receives that information and puts out information back at that same level. And so because of this convergence, we know that what's happening with one tissue in the pelvic floor will influence what's happening with virtually all of them. So if you've got a grumpy bladder, it could be that because you've also got a grumpy bowel. It could also be that because you've got that endometriosis tissue there, that's what we know is that is really badly behaving tissue that behaves similar to the lining of the uterus. It's estrogen sensitive. Because that tissue's there and it's innervated, or its nerve supply is at that same spinal cord level, it can be causing trouble all along the line there with all of those tissues that I've just mentioned. So that is why we need to focus on more than just the uterus and more than just that endometriosis tissue rather. So our pelvic floor, as we had a look at before, is a group of muscles that supports our pelvic organs. But our pelvic floor muscles work really hard and we need to support them too. And so pain from our pelvic organs can often then become a trigger for pelvic floor muscle problems. So if we have a look back at this picture from the Pelvic Pain Foundation, you can see the bottom of the pad there, the bottom there, all of those funny kind of thick lines, they are all the pelvic floor muscles. We're just going to have a little zoom in here on one of them that I've highlighted in endometriosis awareness yellow. So this muscle here is called obturator internus. It's actually a deep hip rotator muscle. So you can see it from the back view in the first picture there. It kind of wraps in and around and attaches to the hip bone. And then if you have a look at that bird's eye view there where it's highlighted, you can see that it forms a part of the pelvic floor, which actually means that we can actually access it intravaginally the same way as we do the other pelvic floor muscles. So, and we can palpate it or touch it and assess it. And why we would want to do that is because of that convergence and because of that endometriosis tissue that is badly behaving, what can happen in our pelvic floor muscles, but especially in that obturator internus, is that we can develop some underlying tension. And we can have that tension and not even know about it. Some of the symptoms of that tension that we may be aware of might be difficulty emptying the bowels, painful intercourse, difficulty emptying the bladder, but other times it can just be there and not be causing any problems. So that tension can be there. And then what that tension can progress into is a background ache. And that might be kind of on a good day what you experience with endometriosis. Almost all of my patients with endometriosis have low back pain, and that low back pain can actually be associated with that tension in the pelvic floor muscles, of course, if other low back issues are ruled out. That tension and that ache can then progress to tenderness. And this is where we can find, if we're having to have a transvaginal ultrasound and the probe is going left to right, we can experience that tenderness, or in intercourse. And then when we're having a flare up, whether that's associated with a hormonal fluctuation, whether that's associated with stress, or any of your other unique triggers for your pain, that pelvic floor muscle underlying tension can then progress into spasm. And that's when that spasm can be that sharp, stabby, quite debilitating pain. And so the cycle can go around and around, which is why we need to address our pelvic floor muscles when we are treating for endometriosis. And this is how we would do it. So most, if not all, things in physiotherapy kind of go along this motto, which is calm it down, build it up. And so the way that we can address our pelvic floor muscles and support them in the way that they support us is we can do hands-on therapy for our internal and our external muscles. So what that would look like is perhaps it's internal vaginal release to those pelvic floor muscles by a pelvic floor physiotherapist, or it could be the physiotherapist teaches you how to do that with a pelvic wand or with your own hands. We can also access those muscles more superficially externally. So that is through your skin or even through your clothes. We can teach you stretches, and I know that the Pelvic Pain Foundation has some really great resources for stretches. And we can also teach you how to do some self-treatment for the external muscles, like with using a ball or a foam roller. Then once things are a little bit more calm, we need to get your coordination really good. So our pelvic floor muscles should be able to activate and relax. And you might have seen that on Instagram or TikTok, or you might have heard of a squeeze and lift and letting go. Both of those are really important. And if we can't coordinate that activation when we need to be activated and the relaxation when we need to be relaxed, that's where we can have some of those troubles that I mentioned earlier. And then after all of that is when we want to start to progress to do some strength training to support the pelvic floor. So yes, we want our pelvic floor to be strong and functional, but we also want the muscles that support our pelvic floor to be strong and functional, like our abs, like our bum muscles, our front of our thighs and our back of our thighs, to really make sure that that pelvic floor is really well supported. So surgery can be helpful, but should not be the only treatment. because even after endometriosis is surgically removed, our muscles and our nervous system may still need treatment. Remembering here that we can address that endometriosis tissue, but all of these other organs and tissues converge at that same spinal cord level, which means that we can take that endometriosis tissue away, or we can take the uterus with adenomyosis completely away via hysterectomy, but we still need to be treating everything around it and calming it down. The other thing about endometriosis that we know is that it is a whole person, whole body neuroinflammatory condition. And so we can get these chronic overlapping pain conditions. And when I delivered this presentation earlier this month, I could see a lot of nods at this slide and lots of people coming up to take photos of this slide, because you could be reading this thinking, yeah, I've got endo, but do you also have IBS? Do you also have that chronic low back pain? Do you struggle with pain in your bladder or what you feel like is a persistent UTI? Do you have pain at the outside of your vagina in the vulva? Do you have chronic fatigue syndrome? Do you have problems with your jaw, tension headaches, or chronic migraines? Or do you suffer with fibromyalgia? So we need to be looking at you as a whole person and addressing all of the factors, not just surgical factors. Persistent pain changes our nervous system. So if you have had pain present on most days for 3 to 6 months, the spinal cord and the brain become more sensitive. Let's have a look. So this is a picture of our nervous system. The nervous system is very trendy at the moment on social media. It is a very real thing, our nervous system. Here it is. It's the brain and the spinal cord. And what happens if we have persistent pain for a long time, longer than 3 or 6 months? Things start to be wired a little bit differently. So if your body was the guitar, the chord there was the spinal cord, and the amp in the background was the brain, what happens is over time we can be putting the same input in via the body, but because of that sensitivity or sensitization, everything gets really, really loud, which is where we can have pain where it shouldn't be. We can have pain or sensitivity to hot and cold, pain or sensitivity to light touch or textures, and we can have pain or issues in other areas of our body because we have had a measurable change in the nervous system. And so that brings me now to my last point, which is to improve persistent pelvic pain. Whole person care is what helps most. So we need to work on the pain triggers, which are our organs, inflammation in the body, and that endometriosis tissue, the pelvic floor muscles, and the nervous system sensitivity. This means we treat through movement. We treat through treating the pelvic floor alongside the endometriosis lesions. We know that surgery can be really helpful. Managing bladder and bowel really well, which is a whole nother presentation and needs to be very individualized. Understanding and learning about your pain, appropriate medication and surgery, and stress regulation, all so that you can live a purposeful and supported life. So physiotherapy, especially when delivered as part of a holistic multimodal program, has really high certainty evidence for reducing pelvic pain, and there's growing evidence for helping people with endometriosis associated pain. This goes far beyond pelvic floor muscle training alone and encompasses all of these different strategies that address the complex musculoskeletal and nervous system contributors to the pain. So here in the clinic with me, this could look like connecting you with your medical team, like me connecting with your medical team or helping you form a team. That can be a lot harder in regional areas. Optimizing bladder and bowel, hands-on therapy as we talked about, pelvic floor muscle relaxation and capacity building, advice about supportive therapies, advice about movement and exercise, reflective discussion about your coping, helping you understand how your medicines work, and of course, relevant recommendation to other services. The way that I like to approach that is to treat you as a whole person. So the first step to that is asking you the right questions and really listening. Then responding to your needs, treating you as a whole person, not just a body part or a condition, generosity of time. All of my appointments are longer than standard, and I like to create a space to provide the care that you really deserve. So my 5 takeaways are: persistent pelvic pain is not just about one organ. Your pelvic floor supports you and it needs support too. Surgery can be helpful but shouldn't be the only treatment for endometriosis. Persistent pain in general changes your nervous system, and whole person care is what helps most. Thank you so much for listening. This is how you can get in touch with me if you'd like to know more.